we have for Research Day 2021, an excellent guest speaker. Dr. Ioannidis is Professor of Medicine, Professor of Epidemiology and Population Health, Professor by courtesy of Biomedical Data Science at the School of Medicine, Professor by courtesy of Statistics at the School of Humanities and Sciences, and co-director of the Meta Research Innovation Center at Stanford, which is called Metrics. He's the recipient of many awards, honorary doctorates. He's a member of many academic honorific societies in the US and Europe, including the US National Academy of Medicine and the European Academy of Sciences and Arts. He has delivered over 600 invited and honorary lectures. The Public Library of Science medicine paper on why most published research findings are false has been the most accessed article in the history of the Public Library of Science, with more than 3 million hits, and I'm sure most of you, if not all, will know this paper. He is among the 10 scientists with the highest current citation rate in the world, with more than 6,000 new citations per month as per Google Scholar. So thank you very much, Dr. Ioannidis, for joining us here. We are very keen to hear what you think are some of the challenges and opportunities for health research and health research methodology during this pandemic. So thanks again, and the virtual floor is yours.
A million thanks for this very kind invitation, and thank you for the introduction, Robbie. Let me see if I can share my screen. So I will try to share some thoughts about challenges and opportunities in health research methods during the pandemic. This is a major crisis, and I think that we have learned a lot, and there's still plenty of things that we can learn in the future in these circumstances. I think that full screen would be better. Yeah. So let me start with some disclosures. I have no conflicts of interest. I need to say that I possess no personal Facebook, Twitter, or other social media accounts, and that I have not signed any petitions, declarations, or memoranda. I think this is important because when we're talking about health sciences research methods, unfortunately, I think that social media, including Facebook, Twitter, blogs, and letters, declarations, memoranda, have been the most powerful research methods in the current environment. They have kind of swept the floor and replaced traditional ways of evidence. So we have to be cognizant about that, but also careful about this. Clearly, we have been facing a major global crisis. The response of the scientific community has been unprecedented. A massive research agenda was launched very quickly. We had great successes and great failures. Both successes and failures offer useful lessons about what we can achieve with different research methods in health research. So let me try to validate these statements, these preemptive statements. First of all, the mobilization of the scientific community. We looked at how many authors have published anything on COVID-19. And by the end of February 2021, based on just the information on papers that had been indexed on Scopus, we found 495,000 authors publishing something on COVID-19. This is an amazing number. It is unmatched compared to any other disease that I can think of, including acute crisis, including infectious diseases within such a short time frame. And what that slide is showing is the mobilization of authors across all science, also looking at the top 2% most cited authors in the second line, and also at publications of these people, close to 200,000 publications practically within a year. This is a map of science. So you see that, of course, the epidemic of publication starts from a fairly more limited scope, but very rapidly it extends across the entire scientific enterprise. When we first analyzed these data with information until the end of 2020, we found that there were authors from 173 of 174 fields of science being mobilized to publish something. Automobile engineering had no authors who had published on COVID-19. By the end of February, even automobile engineering had engaged authors to work on COVID-19. Now, this is spectacular, but at the same time, one wonders whether all of these people were well-trained whether they were cognizant of research methods, whether they even had any relationship to health research and public health research. You can see here the spike of COVID-19 authors as compared to other infectious and epidemic diseases, including Ebola, H1N1, HIV and AIDS, tuberculosis, and Zika. And as I said, the spike is completely unmatched in the history of science. Many of these people published a very large number of papers very quickly. We had someone who published more than 100 Scopus Index papers within many others who published more than 30 or 40 papers on COVID-19. So one is wondering whether it is possible to match quality with quantity when one has such a massive production of information, of perspectives, of data, of analysis, of editorials, and some efforts at integration of this information. There's a number of empirical assessments that have looked at sets, small or large or very large, of COVID-19 publications, trying to assess their methodological quality. Of course, I'm preaching to the converted. You're all aware how important it is to look at the methodological quality for health research. At the same time, we are all aware on how difficult it is to do that, because there's no single scale and no single way to try to appraise quality. But some of the observations were pretty striking in terms of what that literature of COVID-19 publications looked like. Here's one assessment that tried to match papers on COVID-19 with control papers, about 500 papers in each of the two groups. And of course, there's matching based on study design and basically using different types of scores that were fit for purpose for different types of studies, and using also an overall score for quality. The overall quality of the COVID papers was lower. And if you started looking at different aspects of different types of design, you would see that COVID-19 papers tended to be suboptimal in multiple dimensions compared to non-COVID-19 papers. Does this mean that these researchers were worse compared to those publishing on non-COVID-19? Probably not. Many of them were largely overlapping, and many researchers actually moved into producing COVID-19 work very quickly. Unavoidably, this meant that maybe they cut corners in some aspects to try to get this work done very quickly under a certain sense of urgency. Another stark observation is that the majority of these papers, especially in the early phases of the pandemic, but it continues to be very prominent even now, they're papers without data. And they're not really systematic reviews. So for someone who's knowledgeable about evidence-based medicine, this is really the return of expert opinion with a vengeance. We've seen massive production of papers with no data, making very strong statements, sometimes making very strong statements and pushing for recommendations, for action, for something that needs to be done. Everybody's dying. We need to save the world. Again, I think well-intentioned, but probably creating in many cases more chaos and more problems than solving. Of course, we had tons of original articles. We had many original articles that were outstanding. We had also a number of reviews. In a way, we had a very large number of reviews. If you think about people trying to review a literature that does not exist, we had reviews appearing massively even within the first couple of months of the pandemic. A smaller number of systematic reviews, of course, but even systematic reviews rose to the challenge. And by now we have a very large number of systematic reviews and meta-analysis. Here's a comparison of COVID-19 papers and non-COVID-19 papers published in major medical journals like New England Journal of Medicine or JAMA and Lancet. As you can see, these journals typically publish a lot of randomized controlled trials. And in the early days, there was very little to be published for COVID-19 randomized trials. So you see a stark difference in the amount of evidence that is randomized in the non-COVID-19 publications. It's 29% versus less than 1% for COVID-19. Of course, this changed a bit downstream with some more randomized trials published on COVID-19, and I will show you the data in more detail. But It was very stark in the beginning, and it continues to be a difference. In a way, there was an opportunity window that people could publish study designs and data that would typically be considered very weak and very low level of evidence, like case reports or sometimes modeling studies that were completely speculative and unfounded based on empirical observations that were not there. There was a window of opportunity to publish them, even in the best journals. And if you go to Science or Nature, so non-clinical journals, you will see an even more massive influx of these types of study designs being massively published by these journals in the early days and continuing to be published even now. This is a comparison of the quality of the papers on COVID-19 and on COVID-19 in that same cohort of high impact medical journals. Like, again, you see a stark difference. Of course, one could have concerns about the fidelity and the credibility of the quality score that is being used. Nothing is perfect in quality scoring, but the difference is so stark that it's impossible to ignore. Randomized trials. Randomized trials are the hallmark of evidence-based medicine, where you have some higher credibility in the evidence that is being procured. So we did get a very large number of randomized trials launched ASAP in the COVID-19 pandemic. Actually, we have now more than 3,000 randomized trials that have been registered, and we're tracking those along with my colleagues, Lars Hempkins and his team in Basel. This is just showing the number of new trials being registered every month. You see a very dramatic increase with a peak around April of 2020, a relative decrease since then, but still the numbers are skyrocketing. 3,000 trials within practically a year is an amazing feat to just imagine that we could do that. And of course, these trials did get launched all over the world, but there was some heavy predilection in some locations. For example, early on, the vast majority of trials was launched in China. And not surprising, China was the first place that was so hard hit. In fact, currently in the registry, about a third of the trials have been launched in China. As you realize, currently there's no active epidemic wave in China. So it's very likely that these 1,000 trials, or roughly 1,000 trials, most of them will get nowhere. It will be impossible for them to recruit participants. Conversely, we had a slower start in other locations and a very slow start in places like Africa. South America also had a slower start compared to the US and Europe. Some of the places that have been very hard hit have had less randomized trials compared to what one would wish. And of course, this goes back to the preparedness and the ability of research communities to respond very quickly and launch study designs that might be considered to be more reliable. The vast majority of trials were small. This is looking at the same data, but from the perspective of sample sizes. You can see about 50% of the trials had a sample size of roughly less than 100. Which one would question whether it is sufficient to tell anything other than perhaps surrogate endpoint analysis. But we did have also a small percentage of some very large trials that were launched very quickly. And I have to say, they were very successful in terms of yielding results in a very timely manner. Most of the trials were small, of low quality, with questionable visibility, perhaps with futility. This has been shown in multiple evaluations of specific areas and specific interventions. But if you look across the board, you will see that they also focused on some treatments that were highly popular to be investigated. For example, hydroxychloroquine has 304 trials that have been listed in the registries that we have compiled with a planned sample size of close to 500,000 participants. The median sample size was just 160. And then you have a single trial, recovery, comes out with close to 5,000 patients worth of data. And it shows practically no benefit. It shows a trend for increased mortality with hydroxychloroquine, a relative risk for mortality of 1.09 with 95% confidence intervals of 0.97 to 1.23. And one would think, what happened then to all these 300 trials of hydroxychloroquine? Did they continue? Did they stop? Well, not only did they not stop, some of them did, but there were another 60 trials that were registered after the release of the recovery results. You see other interventions like ritonavir, lopinavir, azithromycin, convalescent plasma, tocilizumab, dexamethasone, and chloroquine, all of them having massive numbers of trials being launched. Many of these interventions were also tested in the recovery, a large trial, and also sometimes in some other sizable trials. Vaccines also had a spectacular response in designing a research agenda with 175 trials within a few months. The vast majority of them, of course, were phase 1 and phase 2, but we had phase 3 trials that managed to materialize within a very short period of time. How do you survive this massive information that is accumulating so quickly? One response to that has been efforts to create living systematic reviews and to update them on a regular basis. Your team at McMaster has been very in leading some of these efforts. One step further, you can also have living guidelines that depend on these systematic reviews that depend on these emerging trials. And BMJ has published a number of such living systematic reviews and then also the living guidelines on different interventions. This is work in the making. And I think that we still do not know very well what is the credibility ranking and the credibility coloring of interventions that are so massively, so aggressively, so promptly having evidence generated on, compared to the traditional situation where we have evidence accruing over lengthier periods of time. One gold standard might be these very large collaborative trials like Recovery. And I'm very happy that Recovery did materialize. It was a very bold experiment when it was launched, trying to create a large randomized trial with an adaptive platform, being able to add and to stop interventions depending on what the evidence looked like from preliminary data or from ongoing interim analysis in the information. And one might argue that, of course, no single trial can be 100% correct. But I would also argue that in this situation, this was a very well-designed trial, very thoroughly conducted, and I believe pretty reliable. So it is kind of at least a silver standard, if not a gold standard, of what evidence might look like. What I'm showing you here in this table is some data about the timing. The timing was really amazing. We could get results from a large trial with typically 5,000 people randomized within just a couple of months from launching the trial. This is completely atypical compared to most situations where large trials have taken several years, occasionally 5-7 years. We have examples mostly in cardiology and in oncology. A few of these trials have been done in a few other fields, but getting results within just a few months, and in many cases, fairly conclusive results, was really amazing. Another interesting component was what to do with these results, because the publication system typically takes a long time and we're facing an acute pandemic. So a new way of disseminating information became very prevalent. Many of these trials disseminated results with press releases very early on, and these were very instrumental. Now, press releases are a bit dangerous because, as we all know, they can be sensitive to the excitement of the moment. They may have information that is not validated downstream. You go on a limb on something that has not been peer-reviewed. You try to change the world with media rather than with a full scientific paper. So another way to try to do this would be with preprints. And many of these trials and other studies use preprints. We saw a very massive influx of preprints in the scientific literature. medRxiv, which was a good idea before the advent of the pandemic, suddenly became very popular, and lots of studies were first released as preprints. Again, preprints, though, are not peer-reviewed. And of course, they can attract a lot of criticism if they're about sensitive topics, about designs that may have rooms for biases and for errors. Both pluses and minuses in the process. You have very rapid release of information. Some of that information may be less reliable compared to some other, and you have the scientific community engaging in this, which is good news. You also have a lot of heat and emotion because this is something that every citizen in the world is interested in, and probably this is not good news. In the case of vaccines, we saw the same phenomenon, even more accentuated. We saw actually typically no preprints, we just saw press releases. And then that was all that we got. And then we got publications typically very fast because journals would review these papers extremely fast in a fast track situation. That leaves some shadow for some of these trials. For example, the Russian Sputnik vaccine randomized trials, both the phase 1, 2, and phase 3 have come under scrutiny about some irregularities in the data, about whether they're reliable, whether there's some biases. There has been back and forth with the authors. In other cases, I think the results were far more solid. The vaccines like Pfizer, Moderna, and AstraZeneca have shown extremely nice looking results in randomized trials. And so far, they look to validate their results also in their deployment in the community with the evidence that we have, for example, from Israel or the UK, and also accumulating from other countries. Nevertheless, that was not something that we were accustomed to. We were not accustomed to that rapid sequence and almost reversal of sequence of getting the press release, then getting the approval, then getting the publication, and all of that in very close sequence. And obviously, it led lots of people bewildered. The COVID-19 pandemic has also led to questioning the main modes of collecting information about outcomes, about evidence, about interventions. The typical study that is randomized usually is using its own machinery to try to generate information on outcomes. So you set up a trial, and then you try to see if the locations and the sites that are participating can collect information that you want. However, this takes time, and in many cases, it may take a lot of time. So if we can somehow link randomized trials to routinely collected data where outcome assessments are already available to be used whenever someone wants to analyze either interim analysis or final analysis, that might be a benefit. We had that paradigm up and running, not just in the COVID-19 era, but also before the advent of the pandemic. And recently we published an empirical evaluation in the BMJ looking at situations where we had randomized controlled trials that used routinely collected data to gather, for example, information on outcomes versus those that did not do that, and they used a more traditional way of collecting outcome information. On average, we saw smaller effects in those randomized trials that use routinely collected data. And one might wonder, why might that be the case? Maybe these trials are more pragmatic, maybe they're more extreme in the effectiveness spectrum, in the range from totally efficacy versus totally effectiveness. You expect to have some loss of intervention treatment effect if you move to a situation that perhaps there's less adherence, there's more pragmatism. At the same time, this may be exactly what you want to find out, that this is what the intervention can do under real life circumstances rather than under idealized experimental circumstances in a tightly controlled setting. We also saw a very large number of evidence reversals. COVID-19 was a movie that was running fast forward at fast speed compared to that slow movie of clinical research where people have said that randomized trials are the deathbed of the assistant professor because randomized trials take 5, 7, 8 years to be completed, and an assistant professor needs to be promoted or lose his or her job within a couple of years. Here we had trials and reversals happen within months. One such example is Convalescent Plasma. This is a systematic review and meta-analysis that we published recently in JAMA. If you look at the evidence, when there were only 3 trials published, it looked very good. It looked statistically significant. And there were also observational studies that suggested huge benefits, very large benefits with convalescent plasma. However, with 10 trials worth of data, we see no benefit. Actually, the confidence intervals exclude the possibility of any sizable benefit, at least in the populations that have been enrolled in these trials and in the settings that have been investigated in these trials. This is how the results look like, and you can very quickly see that the diamonds have very tight confidence intervals, pretty much for all the outcomes that we looked at. They're very close to a hazard ratio of 1. For some of the outcomes, there was very limited evidence, so there's large uncertainty, but for outcomes like mortality, the confidence intervals are very tight. Here's another massive reversal. Hydroxychloroquine promoted as the best possible drug to use, used widely actually in the early phases of the pandemic. We recently published in Nature Communications a collaborative meta-analysis where we included not only published data, but also data from all investigators who had done hydroxychloroquine trials and who were willing to send us their information, regardless of whether they had published their trial and regardless of whether they had completed the trial or not. We have used that format to create large consortia, not only for hydroxychloroquine, but also for other interventions. For example, we have looked at that collaborative platform to perform a similar analysis that is under peer review on plasma, like the one on published information that I showed you in JAMA. And we're also doing this for other interventions. In the case of hydroxychloroquine, the latest update, which I think is not what I'm showing you here, apologies for that, shows a random effects hazard ratio, odds ratio of 1.10 with confidence intervals that exclude 1. And therefore, opposite to what had been presumed that hydroxychloroquine may be saving lives, it's possible that hydroxychloroquine actually killed lots of people. If you translate an odds ratio of 1.10 and you have 1 million people among those who died having taken hydroxychloroquine. Of course, this is speculative. I don't know the exact number, but that would translate roughly to 100,000 excess deaths from use of that treatment. How many trials materialized? As I said, we had a massive influx of trials being designed, launched, registered, but when it comes to really materializing, out of these 3,000, only a small subset actually materialized. This is an analysis where we looked at what happened in trials that were launched very early in the first couple of months. So these were 500 trials, roughly 516. And we tried to see how many were published. We also reached out to all the investigators to see what was happening with their trials. We found that 56 trials were completed, 24 were terminated early, 111 were ongoing on schedule, 126 were ongoing but delayed, 39 were ongoing without reporting an expected end date, 155 had not even started or were discontinued, and a few had unknown status. About 70% had started recruiting, and many of them, the majority, could not reach their intended sample size or anywhere close to that. Of the 53 trials with reported results, 13 were posted as preprints, 39 were published in peer-reviewed journals, and 1 was posted on a registry. Trials from China were less likely to be published or be reported. And of course, trials that were otherwise registered earlier were more likely to be reported compared to those that were registered later. How much of the research effort was contaminated by fraud? There's more than 120 papers on COVID-19 that have been retracted to date. This is a pretty high number compared to what we see in other disciplines. Of course, this is a field that has very heightened interest and lots of people are paying attention. So maybe this is the reason for that. But of course, we know that the number of flawed papers is much larger compared to the number of retracted papers. This is a most stunning example, the hydroxychloroquine or chloroquine analysis of observational data that was published in The Lancet. Supposedly, it included information from 671 hospitals across the entire world, but it was very quickly realized that these hospitals had no clue about the existence of this study, of this registry analysis. And apparently the data were fake, and the lead author had to retract the study. Same thing happened with other work published in New England Journal of Medicine by that same company that supposedly was collecting information from around the world that nobody had a clue where it was coming from. Have we made research more useful during the COVID-19 pandemic? Well, we have to go back and ask ourselves, what makes research useful? Unfortunately, I think all of us would agree, based on our daily experience, most of the research that we see published is not useful. I have to say, most of my own research is probably not useful. It's very difficult to do useful research, even with best intentions. Even if you start with the best intentions, there's lots of things that can go astray. And at the end of the day, you need to ask whether research fits these features. Is there a problem base? Is there a health problem that is big and important enough to fix? And in the COVID-19 era, we had a big health problem. At the same time, we had shifting sands in terms of what are exactly the questions about that research problem or health problem that need to be answered, because evidence was accumulating very fast. The pandemic was changing its course very rapidly. Context placement. Have we systematically assessed the prior evidence to inform the need for new evidence and for new studies? And as I said, we had a very rapid influx of many systematic reviews and living systematic reviews. It's not so clear to me, though, that these were connected to the generation of new studies, because it's unlikely that all these 3,000 studies wouldn't be needed for randomized trials, let alone all the other 200,000 studies that were published within just a year. Information gain. Is the proposed study large and long enough to be sufficiently informative? As I showed you, not really. The vast majority of these studies probably had very little potential for information gain. Pragmatism. Does the research reflect real life? I will come back to that. We had some really nice successes with pragmatic studies, but of course, most studies were not pragmatic. Does the research reflect patient priorities, patient centeredness? Have we asked the patients? Again, we have not been asking patients in the past. Probably we did not ask patients who are the population in most studies done in the COVID era just as well. Value for money. Is the research worth the money? Feasibility. Can it be done? As I showed you, many studies were abandoned or were found to be futile. And finally, and this is what I want to dwell on, methods, data, and analysis. Are they verifiable? Are they transparent? And eventually, can we say that they're unbiased? In the past, a very small proportion of studies, even those published in major journals, would qualify for the majority of these criteria. And of course, we're all familiar with the low quality of the randomized evidence across the board. This is an empirical evaluation of the Cochrane database, looking at systematic reviews published within a year and a half, 2013 and 2014. Only 44% of them had grades of recommendation, assessment, development, and evaluation, summary of findings. The remaining, in most cases, probably just didn't have any evidence to be assessed. And of those that did, only 13.5% had high quality of the evidence for the first listed primary outcome. If you ask for reviews with high quality of evidence, with statistically significant results, and a favorable interpretation of the intervention, only 25 of them would qualify. We repeated that exercise 6 years later to try to see if things are any better. Basically, they're not. There's a few topics where evidence has improved over these 5-6 years. There's actually a few that the evidence rating has worsened, probably because people became aware of biases that were not as easily discernible in the earlier days. We're trying to push the boundaries of observational data for many, many years now. And I think that the COVID-19 experience has not been very favorable to observational data. I think that we have many examples where they have been very misleading. Going back 5 or 6 years, this is a paper that we published in the BMJ in 2015. It's attracted a lot of criticism, but we concluded that when you have routinely collected data trying to inform about the effectiveness of interventions without having randomized information, and you base your inference based on the observational data, and then you have a randomized trial, the randomized trial tends to deviate substantially. These are data for mortality, and the deviation, the odds ratio was 1.31-fold, which is much larger than what you would expect from an effective treatment that would reduce mortality perhaps by 5 or 10%. 10% would be amazing. If you can decrease mortality for a common disease by 10%, that's a fantastic effect. So bias would be 3 times larger than that. And I think we've seen that in the COVID-19 era. I think that the faith and trust on observational data as replacing randomized trials has gone down. And I think that this is a good corollary, because I was really worried that we were trusting observational data too much. Pragmatism has also strengthened its position during the COVID-19 pandemic. This is the PRECISE-2 tool with the 9 domains of what really should be considered to claim that a trial is pragmatic: eligibility, recruitment, setting, organization, flexibility in delivery and adherence, follow-up, primary outcome, and primary analysis. We had shown in the past that very few trials are really pragmatic. Many trials claim to be pragmatic, but they are not. I think in the COVID-19 era, we realized that a pragmatic trial, contrary to what is believed, does not take forever to be done. I think recovery is a nice example of a fairly pragmatic trial. It can give reliable results. It can give results on a timely manner. Are there some situations where we have dramatic effects and therefore we don't need randomized data? Again, these are empirical evidence from EMA licensing, and we have the same for FDA licensing of interventions based on just observational data, sometimes even non-controlled data, rather than randomized trials. And on average, the odds ratio is about 12, so which is a very large, dramatic effect. But there's very large variability on these approvals and licensings in the past. Some interventions have been licensed with estimates or indirect estimates of treatment effects that correspond to odds ratios that are very close to 1. So I think that without necessarily saying that these were all wrong choices, we need to revisit very carefully our dependence on observational data. Clinical trials are not a panacea, and I think that many of them could be just wrong and have lots of problems. We're seeing an opportunity here to move towards a more open, flexible, and time-sensitive dissemination of evidence. And this is something that we have not been able to get in the past. These are the data from the most highly cited papers in psychiatry and psychology. In the last decade, we communicated with all the authors, all the corresponding authors of these trials and studies, and we asked them to share the data with us, and we promised to curate them and make them available for everyone to use at no cost to the investigators and their team. We got a few, but the vast majority would not be shared. And the reason for not sharing was that even the investigators had not seen their data. So if you go back to the retraction of the hydroxychloroquine paper in the Lancet, where the professor at Harvard, who was the lead author, had never seen the data from these 671 locations around the world, this is not really uncommon. Most investigators, especially when they work with a company, they don't get to see the individual level data that eventually are the input to the paper that carries their name and their reputation with it. So I think that the COVID-19 experience can lead us to some new rules or new types of engagement and new types of guarantor between investigators, sponsors, and the control of data. In the past, we have not been able to analyze a lot of trials with their individual level participant information. The reason was that they were not available. And when we looked 7 years ago at what did reanalysis of randomized trials show when these reanalyses had been done and published, we found that 35% of the time they reached a different conclusion compared to what the original study had concluded. And one might think, well, maybe these were rogue reanalysts and they just wanted to put the original investigators to shame, but that was not the case. Most of the time, the original investigators were also co-authors in the reanalysis, but in the environment, at least until a few years ago, of you need to say something new in order to publish a new paper, there was no way that one would say, I did a reanalysis and I found the same thing. They had to do something a little different and reach a different conclusion to have a higher chance of getting that work published as a new paper. It sounds very confusing, but this is how the incentives are misaligned, with less transparency, less sharing, and of course, less validity in the results that we get. Finally, the paradigm of large studies. Small studies are fine But of course, if they're alone, they can only detect very large treatment effects. If you look across the entire Cochrane database, you will see lots of small trials that claim very large effects. But when you ask how many of them are seen again, when we do especially larger trials, these are very, very few. They're very, very rare. Some people coming from within evidence-based medicine and its tradition have questioned whether COVID-19 actually may be evidence-based medicine's nemesis. I think that Tricia Greenhalgh has been the most vocal critic in that regard. She has written a couple of papers and essays on that theme. And basically she says, well, just forget it. The basic hallmarks of evidence-based medicine and all of that we are used to with problem solving and PICO, population interventions, comparison outcomes, they just don't hold. The assumptions do not hold. The pandemic is changing very rapidly. You need to respond immediately. You just need to act. Forget about evidence. Just do something. And I really have lots of concerns with that perspective. I can't really see why PICO is not relevant if you have a research question. If it's acute, I would argue you need to do your best to try to get the best evidence for a question that is important and acute. We can try to speculate. We have speculated a lot and we have failed. I think that I have failed. I think many other people have failed when we try to speculate. And this is not surprising. Forecasting, especially for a pandemic, is extremely difficult to do. And even the most sophisticated models are likely to be wrong. We cannot really predict what will happen the next day. We have published that work looking at the best models and their ability to predict what would happen the next day. Both their point estimates and their uncertainty estimates were completely off. Also, models cannot really tell us much about interventions that are very subtle, very complex, very intertwined, very interdependent. This is a paper that we recently published in the Journal of Clinical Epidemiology, where we reanalyzed the data from the Imperial College models that were the key drivers that concluded originally with a very influential paper in Nature that lockdown, rather than event bans or closures of schools or self-isolation or social distancing, lockdowns, the draconian lockdowns were really what made the difference. And if you look at the models that same team, that Imperial College team, a team of amazing, extremely qualified modelists produced, the models that had the best fit to the data showed that actually lockdown had no benefit. And the models that they preferred to publish that had the least good fit to the data showed that it had a benefit. So this is, to me, a classic situation of selective reporting. You have many degrees of freedom when you're working with speculative modeling assumptions, and therefore you can fit whatever narrative you wish with conclusions that fit your purpose. This is the same data seen from a different perspective in different countries that use very different types of interventions. They all achieved pretty much some decrease in mobility. So decrease in mobility could be achieved with very different means and with very different measures and with very different combinations and with very different sequences of measures. But this doesn't mean that one or another very specific measure was the one that had the biggest benefit. I would argue that we need more evidence-based medicine and more higher level evidence compared to what we were used to. I would argue that we need, for example, more randomized trials, even for interventions that are called non-pharmaceutical interventions. We need to test as rigorously as we can these interventions, their dosing, their timing, their duration, their sequencing, their combination, the enforcement of adherence, the weaning process, the measurement of extent of adoption. We have to think very carefully about what kind of response indicators we will use, whether they will be surrogate, whether they will be clinical or hardcore, what kind of target groups need to be studied, and what target groups are ideal for these interventions to be applied, and what is the setting that they need to be considered. And of course, this is a whole new chapter. We have to think about types of outcomes, the timing of measurement, the data collection, the long-term relevance, the cost effectiveness, the placing in context to broader gains and risks. It is a whole new chapter, but I think that we need to write this chapter because a pandemic is not a 2-week thing. It is a several-year experience and adventure, and it's not just one pandemic that we're facing. It's very likely that we'll be facing others down the road. We cannot do that with small, fragmented, biased, questionable studies. Last Halloween, I published that editorial along with a paper by John Carlisle. John Carlisle had been asking for the individual level data of all clinical trials that were submitted to his journal, Anesthesia, over many years. And he was looking at these individual level data and concluded that a large share of these studies can be called zombie trials because there's no way that they can be real. They just have to be fake, or they have to assume that they have very major errors that are really invalidating their conclusions and their basic existence. And I ran a very rough calculation based on his prevalence of zombie trials, and I estimated that there must be hundreds of thousands of zombie trials circulating among us. This is part of the editorial where I estimate perhaps 200 to 300,000 false trials and 100 to 200,000 zombies just from 7 countries. And of course, these are the high-risk countries that analyzed, but there's many others probably that would happen in other countries as well. We also need to think big. We need to think about repercussions of interventions that we need to study in the midterm and in the long term. It's not just the acute epidemic wave. There are many issues about outcomes of interventions that may be as influential or even more influential, and we need to take very seriously into account because they could make a huge difference both for the populations being studied, but also for the globe at large. Finally, we need to grasp opportunities. I think that we tend to see COVID-19 as an infectious disease, but actually everything about health has been redefined. And I would argue that these opportunities also create some possibilities that might be very exciting. This is one such that I tried to describe with Prabhat Jha from the University of Toronto in a paper we wrote in Lancet Global Health. We argued that since we decided that it is fine to shut down everything and destroy the economy just like that, why not shut down the tobacco industry? That would clearly be a benefit for everyone and would not be debated by anyone. So I think that new methods and new perspectives can give us also new tools to deal with some of the existing major public health problems. Final comments. We have learned a lot. I think that this has been a year of tragedy, a year of loss, and also a year of learning. And I think we should use what we have learned. COVID-19 has been a test case for science at large. We have seen a massive recruitment of scientists and massive production of publications. Most publications were unfortunately of low quality, and there was tremendous waste. Some excellent research was done, and it was done promptly and efficiently. Large trials can be done quickly and with reliable results. Adaptive platforms may be the future. We need to use them more. Beware of early excitement. It's very easy to be wrong in science. It's been even easier to be wrong during COVID-19. Share, open, randomize, not only drugs and vaccines, but think about higher level evidence, more reliable in all situations, and monitor closely the evidence. I think evidence-based medicine is here to stay. Many thanks to a number of colleagues who have participated in some of the work that I shared with you today. And many thanks to all of you for listening and for this wonderful invitation. I look forward to see if there's any questions.
Thank you very much, Dr. Ioannidis. That's great. That's a lot to think about. So I think it's good we have some time for some questions. I just want to point out to the people on that are attending here, you may not have noticed when you put the presentation full screen that you cannot see the chat that's next to the presentation on the platform. So make it smaller and you can type your question in the chat there, and then we can see if maybe we can unmute you to perhaps ask the question. While we wait for that, I'm going to look at Alfonso first. Alfonso, do you have a question that you would like to pose?
Yeah, in the meantime, there's one popping up in the chat, Robbie. I was wondering, I mean, I love the idea, why don't we think broad, and what you suggested on tobacco industry is, mind-blowing, but it's possibly not so far from other things we have done. Is there anything that we can learn about journals? One of the was all what happened just meant to, was all representing willingness to help? Everyone stopped doing what they were doing because there was need of working on COVID? Or what is the role of, seeking opportunities and seeing that that's where money is going, that's where research is going, and that's where I'm going?
I think it's multifactorial, Alfonso. I think that journals were overwhelmed. Many of them saw their number of submissions increase by 50%, 100%, 200%. They were under pressure to select papers very quickly. Some papers were published with peer review happening within hours. And of course, this alienated lots of people. Some others were sabotaged. I know papers that stayed 5 months in a journal, even though they were very hot and they had to be disseminated promptly. I think everybody felt like being in a war. And in a war, some of the rules start being bent. And I think this is very unfortunate. I don't really share the perspective we're in a war, therefore we should bend rules. We should just publish that immediately because it's life-saving. No, we need to scrutinize it very carefully, or we should sabotage something, or we should... I think lots of people had conflicts. They always have. Not everyone is a saint who is engaged in health research. Conflicts were a bit peculiar in this situation sometimes. I think that I'm willing to believe that the large number of people who were mobilized had the best intentions. They felt that this is a major crisis and they had to do something about it. But just do something about it does not mean that they would do something correct. And I've seen lots of papers that they're by amazing scientists in their field, but clearly clueless in what they try to do. So health sciences and public health was invaded by saviors from right and left and everywhere. And people who were knowledgeable in health science and who knew, oh goodness, health science research is difficult, it's error prone. Even the best scientists can get it wrong. We get it wrong all the time. Suddenly you had these people coming from disciplines that were not sensitized to all these issues and just massively trying to make a case. So it was a complete mess. It was a party. It was a tragedy. It was all of that.
Thank you. Robbie?
Yeah, thank you, Alfonso. I see there's a question from Anne Holbrook. Anne, I'm going to try to unmute you, see if this works.
Yep, it did. Thank you. Dr. Ioannidis, welcome back to McMaster. It's been great to hear your talk. Just a short comment and then a question. One of the issues we have as physicians, so I'm amongst the group that admits patients with COVID, looks after them once they've recovered. I don't do ICU. We have been drinking from this massive fire hose of information, most of which we know is complete crap. So Alfonso and others have tried to develop a distillery that, that hones down on the good quality information, but even that has a ton of stuff that, I've actually given up looking at updates every day of tocilizumab or whatever. So that's another, I think, significant disadvantage. It's distracting us from our activities of looking after patients. My question is, as a trialist, somebody who runs a small trials group, the recovery, as you mentioned, that recovery trial platform to me was absolutely amazing. In the short period of time, they could produce what looked like very high quality work. And I wondered, I don't know the group at all, I wondered if you could give us a couple of insights as to how that went. I presume it's got to do with a network that's already pre-set up, that's run by a whole bunch of great local investigators and was ready and also had large amounts of funds. But I wondered if you could help us understand how that went so well.
And this is an excellent question. And I'm not saying that we only need large trials. I think the recovery was a very nice example. There was a tradition at Oxford of running large-scale evidence. There was a network that was set up very quickly. There was some funding. I don't think that the amount of funding was so extraordinary because these are trials that can be run with relatively limited amounts of funds. You're not collecting every detailed molecular marker and all these extra pieces of information that make the traditional large trials very expensive. They're very rapidly enrolled and recruited and analyzed trials that can be done at a much, much lower cost. What can be done with smaller sites or small? I think it's unavoidable that we will continue doing many such, and I think that many of them will have value, and I don't think that we should waste the evidence that we're collecting through them. And this is why we have set up that example of these collaborative meta-analysis where we ask investigators to contribute their data. What is a bit atypical is that we often get investigators contributing data from ongoing trials, because if you have a hydroxychloroquine trial, many of them realize that, well, I can stop, or maybe I could continue, but even if I continue, it's unlikely that I will go very far. So they can ask their DSMB if they have a DSMB, or make a decision on whether it's a good suggestion to contribute that information to an ongoing collaboration. I think that it's a great challenge for people who do systematic reviews to really survive that onslaught of evidence that is so fast, so rapid, so easily changing. We need to use our best tools, but even then, I think we will be wrong a number of times. So for the clinicians, I need to give them, I don't know what advice to give. I mean, don't get overexcited. Don't get burned out, because this is a marathon. It's not a sprint. Much like what we know from before COVID-19, lots of these early claims just go nowhere. We do have some effective treatments, no doubt, but the majority of the claims being made are very poor and not sustained. They will just go away. So, don't get too excited. Don't jump on the bandwagon. Take it a bit more easy, because you're overstressed for many other reasons. No need to be stressed by evidence.
Thank you very much, Dr. Ioannidis, and thanks, Anne, for the question. I have another one from Lisa. So Lisa, I'm going to unmute you.
Hi, I think that worked. Yeah,
that worked.
Right. First, thanks very much for a really fascinating talk. I'm looking forward to going back over the recording. One of the questions I have is that I guess in the history in the last few years, really, pandemics and epidemics have indicated that we should be thinking about alternative and novel research methods for trials. I'm just curious to know if we've actually applied any of that thinking, and what's gained traction, and what should we think about going forwards in terms of novel methodologies?
Excellent question, Lisa. I think that recovery is one such example, because it is an adaptive platform. And of course, there have been many adaptive trials before recovery, but I think it's the one example where even a skeptic like me was convinced that it can be done quickly, it can be done effectively. There's many other designs that are more sophisticated. Some of them have a longer history in oncology, perhaps, than other specialties. Probably we didn't use them as much as we could. I think that many of them actually depend on coexistence of surrogates or molecular markers that have not had a very successful story in COVID-19. So, part of their lack of use may have been due to the fact that we have not been very good at identifying these markers or guiding tools that might allow us to have this granularity of randomization and of design. But maybe that will change as we accumulate more evidence.
Thank you, Lisa. And Laura, you also have a question, so I'll unmute you. Are you there, Laura? Maybe not. I can read out the question otherwise. Given that we don't have any RCTs that she knows of on public health measures, including lockdowns to prevent COVID spread, what is the quality of the current evidence that has led to the conclusion that lockdowns do not work?
That lockdowns do not work or work?
Do not work. That's what her question is. Yeah.
I think that the evidence on lockdowns is weak, and I think that it's not based on randomized evidence. We have some randomized trials on some components of non-pharmaceutical interventions. We have one trial on gym reopening. We have a couple of trials on schools. We are pretty small and mostly looking at educational experience. We have, as you know, one trial on masks that created such a huge animosity. No real trial focusing on the most draconian aspects of lockdown. So all of that is either simulations and models that are based on the SIR family, and where we have shown that the inferences really depend on how you build that model. And the only thing I can say is that the best fitting models do not suggest an extra benefit from lockdown, but goodness, this is really soft evidence. And observational data, where again, you have the wave of the epidemic that is shaping its own self, and then it's being shaped by multiple interventions. So any inferences need to be pretty cautious here. My reading of the data and my analysis that I have published suggests that the best fitting models and the best counterfactual contrast suggest that some interventions work, probably the least disruptive ones, including social distancing and banning large events. I think that makes sense. The most draconian ones, shutting down everything or curfew or things like that, I don't think that they work. But there's a lot of uncertainty about it. I would argue then you have to consider what is on the balance. I mean, this is the estimate of benefit on the COVID-19 epidemic wave. Then what is the potential repercussions in terms of other harms? So I think you need to look at the bigger picture, and looking at the bigger picture for an intervention that has questionable benefits, if anything, a trend towards harms just for COVID-19, if it has also some evidence for harms on other dimensions, I would say it's probably not a good intervention. But I could be proven wrong, and I think that we need better evidence. And it's a pity that we're a year and a half and we haven't launched more of these trials that would probably be informative to a large extent.
All right, thank you. I want to be mindful of your time. We're at 2:01 already. I'm not sure if you have a hard stop right now because we have one more question, I believe. Is that okay?
Perfectly fine.
All right, Lahana, I'll let you ask the question.
Hi, John. Welcome back. Now, most, if not all, COVID vaccines have been approved based on interim data. I mean, with all that we know about the potential challenges of reliance on interim results from trials, how worried should we be, if at all, with mass vaccination of the world based on interim evidence?
I think, Hannah, this is a question that we can spend days discussing. It's something that we don't have a precedent. Indeed, we have these trials that show amazingly high benefit with very high success rates of avoiding infections. We also have observational evidence that suggests that the estimates of efficacy probably translate into effectiveness, at least in the short term. I don't know how it would look 9 months or let alone 2 years down the road, whether one would need to be revaccinated or what. We don't have long-term safety data. The short-term safety data, they seem okay, but again, this is a very urgent situation and we have a major crisis. So in principle, I'm very much in favor of vaccinations. I think that especially for people who are elderly and who are at high risk, I'm willing to let go of any uncertainty about things that we don't know and say, goodness, we need to move fast forward with that. When it goes to low risk individuals, like very young people who are healthy. I'm not fully convinced that this is necessarily the best strategy. If someone wants to be vaccinated, this is wonderful. They may also be contributing towards building herd immunity, but I don't feel comfortable with mandatory vaccination. I think there's many initiatives, including at my own university and other universities, that are saying that all the students need to be vaccinated before they return in the fall quarter. And personally, I feel uneasy about that. But then there's 4 months or more until the fall quarter. So within 4 months in this pandemic, we've seen the world go around 20 times more rapidly than it does typically. So it's in the making, evidence in the making. I think we should try to get more evidence. We should not just give a blank check to every single vaccine that comes out, because some of them may be toxic. We've seen already that there's differences in harms for AstraZeneca, for example, versus Pfizer and Moderna. I think that there is a difference in the level of risk for thrombotic events. And we should be pushing for vaccination, but at the same time, just be diligent and try to collect information and try not to overdo it again.
Great, thank you, Lahana. Thank you, Dr. Ioannidis. And I think we need to wrap up this session now, because we have a full agenda for the rest of our research day. So thank you very much for allowing us to go over time for a bit, and for your great presentation and responding to these questions. There's a lot to discuss still afterwards, I'm sure. We're all in the business of looking at the evidence, trying to figure out what we need to do better next time. And that's what we're trying to learn as well. There may be some people that want to follow up after this talk with more questions. So I guess that's okay, so they can do that. But for now, I would like to thank you very much on behalf of the department for joining us, and looking forward to meeting you again sometime.
A million thanks. I look forward to seeing you in person next time. Have a
Yes.
wonderful day.
Thank you very much.
Thank you very much.
Thanks,
Bye-bye.
everyone.